most commonly what we encounter in palliative care are pain, feeding difficulties, and nausea, vomiting, weight loss, difficulties like children feeling lack of energy, fatigue, difficulties in sleeping, psychological symptoms, and so on and so forth. So the key principles we keep in mind is that first we need to identify and treat the underlying cause, and including non-physical causes which are often forgotten about. Then relieving symptoms without, by whichever medications we are using, creating new symptoms because of the side effects. And then considering always non-drug interventions, I would say non-pharmacological interventions before thinking of drug intervention. And then considering whether this treatment is helping. So you have to not only assess but reassess again and again, at least on a daily basis, if or according to every time we see the child. And it is not easy because, as Dr. Jean told us, for pain, the same thing happens in other symptoms. We are dealing with maybe children who are not able to speak because they are pre-verbal or because they have some mental retardation. And it is difficult to evaluate the stress and the symptoms in themselves. Then we have to rely on the caregiver, and they may over-report or under-report particular symptoms. And then we, as pediatricians, we may also be more focused on the disease we are trying to cure, but we are not thinking so much on the suffering, which are the kind of collateral problems, but this is what is really affecting the child. So GI symptoms will be, the most common ones would be feeding problems. The child has anorexia, sore mouth, dysphagia, difficulties in swallowing, then nausea, vomiting. And mucositis is something sore mouth, which we find very easily, we encounter very often in children who are treated for cancer, for instance, or hematological conditions. So it's important to assess, to be able to grade the mucositis. Okay, I'm not going into details of that, but think always like rely on the nurses. I'm talking to as a doctor, but also very important, using ice chips, using any kind of, as we do some local anesthetics, and encourage a lot liquid diet as much as possible. In nausea, vomiting, always the same. Identify the cause, then try to act on that. If we can, if it is drug related, can we do without this drug? Then so that we find, okay, there is an infection, there is any specific clue towards which system is involved, is causing this, is affected, and then we will be able to use the proper drug for that treatment. Always assess for dehydration and severity of nausea. So it's very difficult for a child. It's easy for us to know, to assess vomiting. Okay, the parents can say, we can see there are 4 vomitings, whatever number of vomitings, but nausea is a very subjective symptom. So there is a scale that can be used. It has not yet been validated in India, but it would be good to do that. But I think it speaks on its own. In the same way, we can use the faces for pain assessment. Then here also the child is able to say, at least a 4-year-old child, using this BARF scale, that I'm feeling this. And as health providers, we need to be very attentive to nausea. Is a very debilitating symptom because it doesn't show only outwardly, and that is in most cases the reason for which the child is not taking orally. So we really need to help the children in that. So non-pharmacological measures are very important. Explaining which type of food can be given, the food that the child prefers. avoiding unpleasant odors, avoiding some type of foods that are more difficult, and splitting the medications if the vomiting is associated with medications, or changing the formulation. How often they say, no, cremafine is not suitable for, she will never take cremafine. Okay, we give something different. This particular formulation, syrup or tablets. And maintaining good oral hygiene. And then for the antiemetics, we need to really keep in mind the same adequate and regular dosing, not just to wait. Okay, you give once and then you see what happens during the rest of the day. No, 3 times daily. And thinking of the organ or the receptor that is involved. So I will not go into the details of the antiemetic drugs, but it's important to see what is the stimulus involved, so which receptors do we want to target so that we can give the proper medication. Constipation is a very commonly encountered symptom in children, and it is so easy to, first of all, it's something we have to always prevent. And when it comes, we have to take it very seriously, because in itself, it will cause a lot of other symptoms and abdominal bloating and pain. So identifying the cause and as much as possible trying to treat it, and then increasing fluid intake, fiber intake, and then trying to improve mobility. And good bowel habit training and counseling of the child and the family has to be given. And pharmacological treatment is usually quite effective in treating constipation. And always have a good examination to assess if there is any anal fissure that can be treated accordingly. And the use of suppositories or microenemas, which are usually not advisable in children who have neutropenia, who have low white cell counts in oncology setting. Still, when we are talking about many other conditions, and also in maybe we are providing end-of-life care, the children are not on chemotherapy for oncology children, is usually very safe. But manual evacuation of hard stools should be done only under sedation. When we are faced with diarrhea, often we will have treatable cause, infection, malabsorption, again drug-induced. And okay, it's important always to have dietary counseling, modifications of the diet, and to stress on food and hand hygiene, and then assess the level of hydration. And even though in acute diarrhea we do not usually give antidiarrheal drugs, but this can be very helpful in chronic diarrhea, and in the setting of palliative medicine. And antispasmodic drugs are very effective for colicky pain, at least are helpful. So nutrition is always a difficult problem, and it is especially distressing for relatives, for the parents, saying he or she is not eating, and so we have to see a child who is malnourished, maybe is not able to swallow, or maybe there is not enough food at home. So the first thing is to ensure with our social workers that it is not just a problem related to poverty. Assess for anorexia, nausea, look at the mouth, and encouraging enteral feeding. So oral feeding, small quantities, semi-solid, semi-liquid, are much better than nasogastric tube. By putting an NG tube, we are actually causing more distress in some of our children, if not many of our children. I've not done any study to see it. But NG tube is very uncomfortable for many a child, and they may we are talking about quality of life, so comfort care. So we may have to do without an NG tube. But if the NG tube is well tolerated, we may give maybe night NG feeding, or if need be also just as complement, or also during the day. But giving proper training to the relatives. So it's, as I said, it may be uncomfortable, and then it may lead to GI reflux, gastroesophageal reflux, and there is also a risk of aspiration. I'm not an advocate, advocating no NG tube, of course, but let's always see case to case. And continuing with mouth care, even if the child is on tube feed and is not taking anything orally. But at the end of life, many of us know how it is actually probably better not to force in fluid and food when the child is no longer able to process and stops eating, stops drinking. And there are other ways for the parents to take care of the child, massage, positioning, and other things. Because at that time, we're talking about the last hours, the last few days. Then dehydration has a lot of benefits because it reduces respiratory secretions, abdominal bloating, other edema, ascites, and slowly the child loses level of consciousness and then will sleep away quietly, comfortably. I don't know how much time I still have. It was 20 minutes. Abhishek? Or Jennifer? Okay. 2 minutes, all right. So I think that, okay, cough, I'll insist now on the non-pharmacological measures, which sitting up, we have already seen this a little bit in the workshop, so I won't go into details. It has come in the end of life care workshop, so I prefer to go further, but nebulization is something that is easily done at home. So with or without bronchodilators, and then low-dose morphine can work wonders in the relief of dyspnea, along with low-dose benzodiazepines, which will also act on the anxiety component of the dyspnea. So it helps in children who are already receiving treatment for pain, then this will benefit dyspnea. And okay, if we know that the child may have a hemoptysis, so bleed while coughing or without coughing, then we need to already tell the parents about that. And always better if we can plan it in advance and say that usually, okay, it is not life-threatening unless it is an end-of-life event, but it is something that is very scary, so a frightening experience, and we need to tell them in advance, okay, have some dark sheets at home, try to sit up or lying on the side so that there's not much we can do to stop the bleeding, but tranexamic acid orally will help, and then, if need be, sedation. In the management of seizures, or again, identifying the cause and giving instructions to the family if it is an expected event. Always keep a look at the watch, because we will not do anything in the first 5 minutes, and then medications will have to start to be started after 5 minutes. So we will use some seizure relieving medications, perorally or intrarectal. Then in the children with neurological disorders, spasticity and dystonia can be, we can help them avoiding triggers that would be noise, light, unfamiliar contacts. And all these are very useful advice to be given to the family, gentle handling, and how to best look after the child. And physiotherapy is, of course, very helpful to teach the parents how to provide that physiotherapy at home. and other medications will help to reduce to some extent the spasticity and dystonia. So I will not have time to go into psychological distress, but these are very important components which we should always explore, because the child will not express it, and the reaction that children have to the distress of their parents and other caretakers. So music and other play therapy will be very helpful. And let the children be able to speak about what is when they feel very low, fatigue is very probably one of the symptoms we cannot fix till the end of time, but always adapting the play to their current capabilities. I won't speak about delirium, but only that delirium and other intractable symptoms at the end of life, whether it is intractable pain, dyspnea, massive bleeding, seizure, can be relieved with palliative sedation, which would be infusion of opioids, benzodiazepam, neuroleptics. And the aim is only to provide comfortable death in which it may be reversible in some cases, in which we want sedation only for a while, or just accompanying the child. So the parents have to keep nursing, touching, talking to the child, so that active care is still there. And that's all. Thank you very much.